Thank you very much. This is going to be a very much roll your sleeves up, nuts and bolts discussion, because this is our experience of using NAVA at the University of Virginia. We started using it about 2 or 3 years ago. We've recruited over 50 patients, probably now about 70 or 80, and this is really what we found. Few disclosures, there. The NAVA catheters were supplied to us for us to do our study, and what we really looked at was taking patients who were difficult to wean. So they basically failed at least one spontaneous breathing trial. We did this in the adult ICUs, basically the surgical and the medical, although it did turn out for various reasons. We focused largely on the surgical ICUs, and we got 50 adult patients enrolled into the study. As I said, they'd all failed at least one spontaneous breathing trial. This was a difficult to wean group. As you can see there, 75% of patients had already had a tracheostomy. The average duration of mechanical ventilation prior to being enrolled in the study was 2 weeks. This wasn't a sort of, straight from the OR, intubated in the study 2 days later group. They had failed, most of these patients had failed at least one spontaneous breathing trial and probably failed at least multiple attempts at extubation as well. The main mode of ventilation that we used was pressure support, as you can see, with assist control largely used in a few patients. Largely, pressure support on the surgical ICUs. Assist control was more favoured on the medical ICUs. So fairly conventional stuff, but as I said, I think a difficult to wean group, by any consideration. This was the cause of the etiology of the respiratory failure. As I said, I work on a surgical ICU. For various reasons, we were able to recruit patients better on the surgical ICU. So therefore, you can see that most of the patients were post-surgical and struggling to extubate after that. There was a fair number of comorbidities, though. These were old patients, and as I say, a lot of them had COPD, coronary artery disease, various other disorders as well. Because we have got fairly good at doing the wake up and breathe thing, and most of these patients were off sedative infusions. You can see of the 50 patients, there was only one patient on a propofol infusion. Few were agitated on Precedex. It was largely a surgical population, so fentanyl was probably the most common infusion used there. But the majority of these patients were off sedative infusions onto PRN dosing, and we were really waking them up and doing daily spontaneous breathing trials on them. And this is what when we introduced the NAVA, we decided we wouldn't do anything incredibly fancy. We'd try and match it to our existing protocols. So we targeted the NAVA level to a 6 mils per kilogram tidal volumes, and that is what we've been doing on pressure support and assist control before that. And to the credit of our RTs, they're pretty darn good at doing that. 6 mils per kilogram is the maximum tidal volume that we'll use. We give, if we put the NAVA catheter in, found that there was an inadequate EDI, we then switched to patients to a period of CPAP. We'll come to this a little bit later because this was important. We'd hold the sedation. And then we look at put patients back on their baseline setting, looking NAVA preview to see if there was any asynchrony or how they were behaving, and then switch them. If they were on pressure support, we'd switch them to assist control. If they're on assist control, we'd switch them to pressure support, just to see how those two modes compared in NAVA preview and actually looking at what the diaphragm was doing in these patients. And as I said, because we were trying to match the NAVA protocol to our existing protocol, patients continued to have their daily spontaneous breathing trials where we just simply drop the NAVA level to 0 and see how they did for a period. This you can see, our starting NAVA level, 1.3 centimeters per microvolt. It stayed pretty close. Most of these patients, as I said, they'd been ventilated for at least 2 weeks beforehand. Their respiratory status was fairly stable, so NAVA levels didn't change very much. The average number of days we used NAVA for was 4, but it ranged anything from 1 up to a patient of 10 days on NAVA, without any problems. Tidal volumes, as you can see there, we really pre and post, we were not over-assisting patients. We can't, I think we can look at those tidal volumes. These were standard American adults, not small. That's right. Yeah, about that. You can see for that, we were not over-assisted. And I think the other clue to that is look at the respiratory rate, pre-NAVA and on NAVA. A number of people have shown that if you put people on over assist levels of pressure support, your respiratory rate drops. But and they've noticed that switching from pressure support down to NAVA, you see a drop off in your respiratory rate. We didn't, which makes us feel again that we were not over assisting patients grossly prior to this. So I think that's kind of important. So I'm just going to go quickly, just a little bit off, one tangent, say what we found. Literally about half our patients, they tolerated NAVA without any problems whatsoever. We didn't have to adjust anything. They just did it. We did the spontaneous breathing trials. Once they passed the spontaneous breathing trial, we then let the primary team decide whether they wanted to go ahead and extubate the patient. The most common technical issue we had was loss of the signal, which was often just, you just had to reposition the catheter and you got the signal back and it was not a problem. The most common problem overall, as I've said to a few people I've spoken to the audience, was not technical. It was an attitude problem on the staff. A lot of our patients have been trached and pegged, as I said. They were a difficult to wean group. And staff just did not want an NG tube put down their patient, which is why, I think, over 90% of our patients are on surgical ICUs because, especially on the medical ICU, they were very intolerant to having NG tubes put down. And sometimes we'd have to ridiculously have two catheters in, a feeding catheter and a NAVA catheter. Things we've got to try and move forward. Failures. There was 8 we considered overall. 6 of those, I think, were really patient factors. 2 of the patients post-lung transplant had complete diaphragmatic paralysis. We put the NAVA catheter down, there was no EDI. I went, oops. We tried all the CPAP maneuvers, there was still no EDI. We then got ultrasound studies of the diaphragm and showed the diaphragms were completely paralyzed. Patient with Guillain-Barré syndrome was actually triggering the ventilator. NAVA catheter went down, no EDI. Again, studies showing that, again, they had complete diaphragmatic paralysis in that situation. 2 sedated, that improved with decrease in sedation. We came across a couple of patients, at least one here, that was just too agitated. Their breathing rate was over 40 times a minute. And clearly, we put the NAVA catheter down, their diaphragm was going 40 times a minute. We found this in agitated patients, particularly patients with encephalopathy, head injury. But sometimes, the staff would turn around and say, look, we understand the diaphragm's still contracting 40 times a minute, but could you please put them back on pressure support because then it looks better on the ventilator. And you can't fight some things. There was a couple, and there was one at least we weren't unable to pass catheter despite multiple attempts. We found 2 patients that I think we generally found problems with them, that we couldn't get a decent NAVA signal, no matter what, no matter how much of manipulation, and we just we couldn't effectively ventilate the patient at the highest NAVA setting, but that was 2 out of 50 patients. The rest, as I said, did well, and I'd say nearly 50% of patients were able to tolerate NAVA with literally no intervention on the part of the staff. This was the problem we found that was interesting. As I said, we put these EDI catheters in and we studied them on their baseline vent mode, be it pressure support or assist control, and then we switched them over. And we found this almost complete EDI suppression, which I'll show you the pictures of in a moment, in at least 6 patients, it was just 12% of our patient group, on both pressure support and assist control, and a further 6 patients on assist control only. So almost 25% of our patients on assist control were having complete EDI suppression or diaphragmatic suppression for these. Now, for all of these, we were able to put them onto CPAP, sometimes back off the station, and we were able to generate a NAVA signal enough to, we could ventilate these patients. This is often the problem. This is a patient, as you can see here, volume control, NAVA preview, and the EDI trace should be at the bottom. There isn't one. It's just completely suppressed. Pressure support, this is the same patient on 12 of pressure support. Now you get a decent EDI signal, same patient. But I say going back on volume control, nothing there, completely suppressed. And this is occurring over minutes that you're able to shut down this patient's diaphragm. We had one patient very nicely on pressure support that we were able to switch the EDI on and off simply by going the pressure support from 0 to 12. And you go up to 12, you had no EDI, drop down to 0, you had an EDI back again. This is the patient on NAVA, ventilating very happily on a nice NAVA setting there, with a perfectly normal EDI value there. Patient on pressure support here, very suppressed EDI there. On NAVA, able to ventilate them, again on that. Patient on PM, pressure regulated volume control, nothing. Completely and utterly suppressed. put them on NAVA. We were able to ventilate them on NAVA and wake up their diaphragm again. So there was a number of issues with this. Looking at the patients where we had EDI suppression on both pressure support and assist control, what could we say at them? Again, the number of days of prior conventional ventilation was about 2 weeks before that. We were able to ventilate them satisfactorily, 5 out of these 6 cases using NAVA for periods anything between 2 to 6 days. There was one patient where we struggled to ventilate at the highest NAVA settings. They eventually developed, hypercarbia. I mentioned that at case 42 at the bottom, and we had to switch back to assist control. But the vast majority of these patients who had completely shut down diaphragms on assist control and pressure support, we were able to switch to NAVA very quickly and happily ventilate these patients for anything up to 5 days. The group that had assist control, again, mean number of days of prior mechanical ventilation, 19. Again, a difficult to wean group. We were able to get, in this group, on fairly low levels of pressure support, we were able to get a reasonable EDI, and we were able to switch these patients to NAVA and ventilated one of these patients up to 10 days on the NAVA before we were able to actually extubate them in the end. So, as I say, on assist control, they were being their diaphragms were being completely shut down, and this was 25% of our patient group using assist control that we found this phenomena, and it wasn't until we actually put the EDI catheter in and that we recognized it. What was the cause of it? One was, these are the possibilities, went through our heads. One is sedation. This is a study where they gave a bolus of propofol, looked at the EDI, and it does shut down the diaphragm. But as I said before, majority of our patients were kind of way out on the weaning curve. Their sedative infusions had been completely shut down, and very few patients were actually getting sedative infusions. They were awake, getting just PRNs. So I don't think that's a factor. How about fatigue? Work from the Boston group, done in kids, suggested that, your ability to generate diaphragmatic contractions, or as your diaphragm fatigues, your EDI may go down, somewhat. They've found, again, looking at the group here, that if you look in the bar graph on the right, your ability, the grey hatched areas, those patients that couldn't do an extubation trial in these groups, and they had lower EDIs in that setting, or their ratio of tidal volume to EDI was greater. So the EDIs were a lot, as I say, they postulated in the end that fatigue was causing the low EDI. I don't think that was the case in our group, because if that had been the case, and we had, I don't want to understand how our baseline vent settings were causing fatigue, but one would not have expected that to improve with a CPAP trial. And what we found with a lot of these patients with a very suppressed EDI on their baseline vent modes, we put them on a CPAP trial, give it a few minutes, and their EDI would start to appear back up again. That doesn't follow if the fatigue was the cause, so I think we dismissed that. This, I think, was the problem. Even though I think, as I said, our tidal volumes were not excessive, and our respiratory rates did not change, when we switched to NAVA. Clinically, I don't think we were over-assisting. Jennifer has done some, good work here, showing, in patients with, acute lung injury, that the higher you go up on the pressure support levels, the lower your EDI comes down. So I think, it's clearly been shown that, over-assist on pressure support, and one would expect, assist control suppresses your EDI in these situations. But it didn't go down to 0. We found this one example from Jennifer and Krista, published a number of years ago now. And this is, pressure support, complete shutdown of the EDI. And I think when the patient went basically on NAVA, just as we found, we could now restore the EDI and ventilate these patients. So, these type of patients have certainly been out there. And Paolo, I think, just showed a graph in his presentation of a paper like this. I think what was concerning for us is just how many of these patients were out there. As I say, 12% of patients on pressure support, 25% of patients on assist control had complete EDI suppression. And how do you recognize it? All these patients were triggering their ventilator. By the way, including the 2 patients, or 3 patients, there was 2 of the patients post-liver transplant, one with the Guillain-Barré syndrome. These patients had diaphragmatic paralysis, but they were triggering their ventilators quite happily. And all 12 of our patients that we found this over-assist on were triggering their ventilators quite happily. There was no real clue if you looked at pressure flow waveforms about what was going wrong, and we have to presume that, that these patients were triggering the ventilator with their accessory respiratory muscles. As we've educated ourselves, we've got kind of better at recognizing these patients clinically and looking at their respiratory pattern. You can now see those patients where they're really sort of guppy breathing. You can see it's their accessory muscles that are actually triggering the ventilator. And the diaphragm is pretty shut down in these situations. I think this has concerns. And one thing that concerned us when we put these catheters down and we found this EDI suppression was, how many days has this been going on for? These patients have been ventilated for 2 weeks, on these modes, and when we got hold of these patients and enrolled them in the study, we probably had them on their lowest vent settings. So if on their lowest vent settings they had complete EDI suppression, what was going on before that? So one of our real sort of things we sort of went, ouch. Just how many days have we been completely shutting down the diaphragm on, in these patients? I think this has, a real concern with the whole business of ventilator-induced diaphragmatic dysfunction. I think there's more and more interest in this. Studies out there showing quite happily that both in animals and humans, this occurs very quickly. Nice study here showing that, the force of diaphragmatic contraction from number of days, that you actually from intubation, and literally within, you can see here from day 1 to day 6, it just falls off very, very quickly. The diaphragm obviously needs to continue working for it to remain active and just remain a forceful muscle. So as I say, this had big concerns for us, because how many days had we been shutting down our patients' diaphragms with what we thought was fairly low levels of pressure support. I mean, just going back to our patient group, the highest pressure support of that group was 14. And most of our patients were on 10 to 12 centimeters of pressure support, pulling tidal volumes under 400. These were clinically not over-assisted patients, but clearly they were. So I think we found this worrying. And I think the ways that using NAVA has changed our practice is that if we were pushing for daily spontaneous breathing trials in the past and just saying, look, you've got to do these, now we're insisting on it. They have to be taken off their whatever mode they're on and given daily spontaneous breathing trials, irrespective of their level of pressure support. I think that has to be done to try and sort of, allow the diaphragm to potentially recover. We also will tolerate higher respiratory rates. We're dealing with the whole problem of rest modes at night. When patients, or staff want to go up on the tidal volumes, on the respiratory rate, or the pressure support to try and drop respiratory rate, and we're going back, guys, you may not actually be decreasing the work of breathing by doing that. So I think, we're changing our whole thinking about rest modes and sleep modes, on the ventilator. So NAVA's been a big eye-opener for us. I think it's making us reinforce our existing practices. It's making us look, I think, a lot more harder at, what we're doing. Particularly, I think, as I say, what we're doing at what we think are safe levels of ventilation in these difficult chronic wean patients, it's clearly, they're not safe levels. And this is why, we wonder why we can't get these patients off the ventilators. I can slip over that. Okay, I think I'm probably ahead of time, but any questions?
Thank you very much. Any questions from the audience? I've got one quick question to start. You said that this is how NAVA has changed it. It seems to me that the key here is the NAVA catheter and measurement of EMG. Is that what it is, or is it NAVA per se, where neurally assisted ventilation throughout?
I think it's, it's being able to see what the patient's diaphragm is actually doing.
Right.
I mean, because that.
Why don't you keep that on? Just.
Sorry. That information was just not available to us before. So I think, what's really, as I said, this concern that we have, finally we can see what the patient's actually doing, and realizing that we completely, as I say, we'd effectively iatrogenic paralyze these patients' diaphragms, and we had no idea that we were doing it prior to this.
So essentially as a diagnostic tool, using the catheter as a diagnostic tool.
It's a diagnostic tool. I mean, we've happily ventilated these patients on NAVA, as I said, for up to 10 days. I have no idea, but we didn't do this as part of a randomized controlled trial, so I don't know if they'd have extubated after pressure support of 10 days. But all I can say is that it was feasible to use NAVA for that long a period, and we didn't have a problem with it, and it worked quite happily in patients that were otherwise we'd found to have diaphragmatic shutdown. It does make us point out, though, I think, as Paolo said, that just the study of, looking at airway and air pressure and airflow graphics is horribly unreliable to know what's going on with the patient. And I think that's the big thing we found with NAVA. As you said, it's a diagnostic tool. It gives you far more information about what the patient is actually doing, which has been valuable.
One question at the back, and then we'll have to move on.
As you mentioned, there were about 75% of patients who are trach patients. So can you just elaborate what did we try on trach collar on these patients, or if we did SPT, what was the setting for spontaneous breathing trial on these patients?
We would just set the NAVA level down to 0, which is effectively, a spontaneous breathing trial, or we would put them on trach collar and just keep the NAVA catheter down, which is quite useful actually, because you could then see what their sort of, EDI was doing, on the trach collar. And we started getting a little bit more interest in that, seeing if that would change over time. It was just another focus of interest to see what happened as you put patients on trach collar trials or spontaneous breathing trials to see what their EDI doing. The hypothesis thinking that as they began to work harder, if they began to fail a spontaneous breathing trial, perhaps their EDI would change, go up, go down, and give us some, objective physiological clue to what they were doing. So I think it's something we need to probably look at a little bit more to see if as I say it's in these patients on spontaneous breathing trials, what is their diaphragm actually doing underneath?
Thank you very much, Stuart.